Welcome to the show. Welcome to Dental Elements, turned consultant, turned podcast host. Today on the show, our guest is Mohammad Kamal. He is a renowned pathologist, CEO, and founder of Omni Pathology Lab. With an impressive track record as a sought-after international educator, Dr. Kamal has shared his expertise with audiences worldwide. His commitment to advancing the field of pathology and his passion for education have earned him a well-deserved reputation as a trusted authority. Welcome, Dr. Kamal.
Thank you so much for having me on. I am a pathologist. I got my medical degree. I was born in Washington, D.C., but I grew up in Egypt. And I got my medical degree at Cairo University. And I came to America and I pursued my medical career here. And I did a residency at Harvard UCLA, and I did a fellowship in GI pathology at UCLA. And immediately after I finished my training, I did some work with larger organizations. And at one point, I felt that I needed to start my own lab. And I had a certain vision, things that I learned over the time. Before pathology, I did some research in medical devices, and I was part of a small group that became a spin-off company. So I had this entrepreneurial spirit in me, and I felt, okay, let me just try to do this and start my own lab and see if I can, employ my vision into a medical organization. So I started Omni Pathology. The lab was opened in 2009. And from there, it was quite an experience, because I said, I'm going to build it specimen by specimen. And that's exactly what we did. So we kept growing, we kept adapting. And I think when COVID happened, we have a really great story about how we developed our COVID test. And we were one of the earlier labs that did a COVID PCR testing. And we developed our own test because there was shortage of, supplies, and the larger labs got a hold of the supply chain, and we were left with basically the need to develop our own, and we managed to do that. So our pathology story is quite nice and compelling. And of course, GI pathology is one, but molecular testing for infectious diseases became our area, and we gained a lot of confidence when we developed our own COVID test. So that's the pathology part in brief. And then the art part came out of the fact that I have always appreciated the beauty in the pathology images. And as you mentioned, I teach, and I have a lot of, in my library, a lot of digital images of pathology slides that I use for teaching. And a friend of mine at one point looked at some of these pictures, and she felt that this could be a good thing to decorate our walls with. And I just took that idea and I started to work with the art, and, it evolved into something that gives me a lot of satisfaction when somebody sees a picture of cells and they think that this is artistic and they admire it. And then they see things that I've never seen. It became like an abstract way to show things, and it reflects. I always say that this art is about the viewer, because it reflects their mood, and even their view of things. So some people see things in a very open and bright and optimistic way, and some people see things in a very kind of like dark and scary. But that's the beauty of it. One image can have two different reactions from two different viewers.
Wow, I would love, I want to see some art. Do you have some hanging in your office, or is that, I think it's exciting.
The conference room is full of this microscopic imaging art. And then I have hallways also that have this. And then I have, of course, my website, which I can share.
Chemo Fine Art?
Yeah, and chemo is my nickname. In Egypt, if you're named Mohammed, nobody calls you Mohammed because everybody's called Mohammed. So you go by last name, and my last name is Kamal, and chemo is the nickname for Kamal. Here, William is being called Bill. In Egypt, Kamal will be called chemo. Nothing to do with chemotherapy.
Yeah, but maybe it kind of persuaded you to get it like.
And it's KIMO. Yeah, maybe that's KIMO Fine Art, all one word.com.
Okay, KIMO. Okay, and then do you sell art there as well?
Yeah. So you said that there's a way that people can click and request information about the piece. And then,
so us infection control nerds could have, I need some art on my back wall.
Oh no, yeah, that would go very well, actually.
Yeah, I'll check it out.
Yeah, a lot of it.
Yeah. And I see like in some art, like you were saying, or pathology or ultrasounds, I see like faces and like,
Yes.
well, but that's not a baby. Like, what about like, who's that man back there? Like you see faces and things and like that. And then I guess that would make sense. It's kind of what you see. And so you developed your own COVID test. I mean, that's remarkable. Like I hear things that people, innovations and stuff during COVID and during the need, but that's like
worked with the marketing company, and they were helping us develop our brand. And the team is called Gumas, if I may mention their name, the Gumas Marketing Agency. And what they did is they interviewed us, interviewed some of our clients and looked at what we do and looked at our story and everything. And they came up with a tagline, which is Omnipathology, led by science, driven by service. And I heard that tagline, and the first time I heard it, I didn't really connect with it right away. And it had a lot of convincing on their end to say, no, this is really a good tagline. And it grew on me. And then 2 years later, COVID happened. And then we found ourselves developing a COVID test and help the community. So it was really true representation of what we do. And it reflected so well on my perception of the team that I worked with, and that they really saw that ahead. And what we did with our COVID test was unique because we said we're going to help our community. So one of the things that we did, if you recall, there was a big shutdown, the lockdown when they shut down all elective procedures, medical procedures. So a lot of our clients that typically do procedures and then send us biopsies, they were completely shut down in April and maybe part of May of 20. So what we did is that we went to these doctors and said, when the shutdown is done and when you want to open, we will help you screen your patients and screen your staff so you can bring people and feel safe about having a lot of them getting back to business. And then we have also our executive director. What she did is she said, we need to really develop something to help schools open. So she basically started this school program where she started developing the programs and provide resources for schools to be able to swab their students so that they can be back to school. And we started doing that. So that helped a lot of our local schools get to open and feel safe and to isolate positive patients and help other people from getting infected.
That's fantastic because you feel so helpless, during that situation. So to be able to do something and help people in that way. Yeah. Yes. And then once again, you had the name first before the product. So that you're onto something.
Yes.
Yeah. Well, yeah, that's fantastic.
Yeah, thank you.
And so, so when that was shut down, so luckily you had that. Because you were shut down too, right? Like pathology and healthcare, all those services, unfortunately, didn't get done.
And here's what's really interesting about us, which is a lot of people were closed, but we were open because we were working, developing the test. And then we envisioned that we're going to need people to run that test. So we're very proud that our organization, we did not lay off a single person during the shutdown. In fact, we started hiring people once things opened up. And once we started having the test, we needed people to help with different parts in the lab, accessioning and processing and everything. So we actually started hiring people, and it was really a good experience because in my medical career, I graduated medical school in 1989. And I was telling people at the time that in all of this time, I never felt fulfilled as much as I was during the COVID time.
Yeah, because you're helping kids and procedures and employing people and other people. Yeah, that's
exactly. Yeah.
Yeah. I know. I was just talking to somebody, interviewing somebody else too, talking about it's not just about the success of your business, but it's the feeling of giving and helping. And there's so much, so much more fulfillment too that you're doing with your work.
Yeah, I mean, because today we hear a lot about the Spanish flu that was 100 years ago, right? And I tell people that it is conceivable that you become a grandparent and you would talk to your grandchildren about the COVID pandemic, just like what people talk about the flu pandemic that happened last century. And I would tell them that, we're going to have really good stories to tell about that time.
Right. Now that it's in hindsight, hopefully, mostly, and seeing pictures of people now with masks and things. And now it's a story that we live through. We live through history. So it's horrible, but in a way it's exciting, like if you have to find the good stuff, of course, it's mostly bad. And there's a lot of good.
Yes. And the exciting part also is I think that the pandemic highlighted the need for medical technology and the need for continuous support for medical technology, medical enterprises, medical organization, science education. I feel that probably the pandemic will find out that a lot of people decided to get into science because of what they saw with the pandemic, losing a loved one, something like that. That I think that this would be a long-lasting impact of the pandemic.
Yeah, like shed some light on some issues for sure that needed to be lit up. With your pathology, pathology lab. So as far as dentistry, I see here that you do the oral HPV tests too,
Yes.
like for throat cancer. And
Yes,
because I know, as a hygienist and in dentistry, that's something that I look for, every time I see a patient. And unfortunately, I've lost a would-be father-in-law to that, throat cancer. So it's common. And I've had other people that I know and close friends whose fathers have had it. Luckily, they're okay. But I've heard I've heard how horrible it is. And then with shut down and then not having these tests, and now we're seeing the backlash from that as well. And so the importance of having these labs and having these pathologies done. And how do you work with that, with the tests, with the oral cancer tests and the?
So here's how this came along. So we always had HPV testing, which is a PCR test that we are offering to our GYN clients, done on cervical pap smears. And years ago, I want to say maybe 2017 or 18, we started to hear from physicians asking us about if we have an oral or oropharyngeal HPV test. The cervical HPV test that we are running is FDA approved for the cervical sample. It's not approved for anything else. It's only approved for cervical samples. But Omnipathology is designated as high complexity laboratory. So a high complexity laboratory can develop what they call lab developed tests. You could take a test, you could develop your own test, which is exactly what we did with COVID, right? We developed our COVID test because we are a high complexity laboratory. So we have a platform that runs a robust HPV assay. So we said, okay, why don't we take that study, that assay, and validate it on an oropharyngeal sample. And the question here, oral versus oropharyngeal sample, and I'm just going to briefly say that they are both squamous cell carcinomas. Oral and oropharyngeal, which is throat, are both squamous cell carcinomas. So they share risk factors: HPV, smoking, excessive alcohol consumption. All of these are risk factors for developing cancer. So what we decided to do is that I felt that an oropharyngeal sample is going to really address the issue with the throat cancer, right? Because you just go to the back of the throat and swab, and you swab exactly the areas that most cancers are developing, tonsils and base of the tongue. So we decided to do this. So we ran this validation. Funny, we started actually working on that validation towards the end of COVID, and we found that we had a really very good assay. We have a sensitivity of 95.2%, a specificity of 100%. And we said, okay, so we started marketing it. Now, as I was thinking strategically how to position that test, I just realized that dentists and dental hygienists have unparalleled access to patients' throats. Nobody's looking at patients' throats as frequently as dentists and dental hygienists. If we wait for ENT doctors, people live their entire life without seeing an ENT doctor once. Right. So I think the number one target we decided that should be dentists and dental hygienists. We're going, of course, to the GYN doctors. We're going to the general practitioners, primary care physicians for that. But I felt that this is a screening that is best performed in the dental practice. So we started doing this, and it was interesting and exciting because we've never marketed anything to dentists. So we're learning the environment and learning about a lot of things about the dental practice. But what's also interesting is that luckily we started to learn about the initiatives in the dental industry about, the oral health is a gateway to overall health, that the link between the two, and that now they want to look at patients as a whole. It's not just teeth. It's not just the nice white smile, right? We want to basically look at the patient as a whole which is really a no-brainer. If you could find a systemic disease that could be diagnosed by screening at a dental practice, people go to dentists once or twice a year, that is ideal. So now our biggest battle is to educate more and basically get through the barriers. And I'll talk to you about more, later in this conversation about the barriers that we're facing.
Yeah. I totally agree. And so many times you go to the doctor, they don't look in your throat unless you go there for a sore throat. I mean, they have so much to look for, you can't. Yeah.
And then the other thing is that if you think about how throat cancer presents, most cases now are discovered when a patient has a lateral neck mass, which is a metastasis to a lymph node. That is way too late. This is beyond stage 1, right? So if you think about the cancer and how it develops, and it starts with a lateral neck mass, then that's too late. What we want to do is we want to come up with things that can allow us to proactively identify the patients that require that extensive screening, so that we may be able to identify a pre-malignant lesion, precursor lesion, and when you remove that, then you could significantly enhance the patient's chance of avoiding cancer down the road, right?
Right. You recommend going over the health history and looking for identifying factors that they tell you about. I mean, some things they don't tell you about, but you can see.
Excellent. So let's talk about the first barrier is having a conversation about lifestyle and sexual practices in a dental office. It's somewhat foreign, right? It's not a normal thing. When we talk to them about this, then it is HPV-related cancer, and HPV is the most common sexually transmitted disease in America. Then the conversation about sex and about lifestyle and all of that happened not because we want to talk about it, because there is a disease that we're trying to screen for that should be the way to open that dialogue. And I think with more education to the practitioner and the patients, this becomes easier. So that's the main barrier, is to start educating the patient about what we screen for. For example, as a dental hygienist, there is a lot of palpation of the neck, right? That palpation is to do this. So if a patient is being told we're doing this because we want to screen for masses in the neck that could be, from the throat, then that will start. Okay. So if we get to that point, I think it becomes easier for the patients to understand why do we screen for HPV. So everything I will tell you about HPV in the throat, it's exactly the same case in the cervical canal. So for example, and of course the advantage and the reason cervical cancer has declined is because there is a quite effective screening program for cervical cancer with pap smears, HPV testing of the smear, and then if a patient is positive, there is a well-defined guideline what to do. You do a colposcopy, you look with a scope, and you take biopsies from any abnormal lesion, and there is a follow-up regime that is well established. We don't have that in throat cancer, right? So what we will do is that we think so some of the resistance or the barriers, some people will say, why would I screen for HPV if it resolves on its own? Yes, a good percentage, the majority of HPV cases resolve on its own. But that's exactly the same thing that happens in the cervical canal. And you don't hear anybody in the GYN community saying that we don't need to screen for HPV because it resolves on its own. It resolves on its own in the cervix and in the throat. So, but the most important information here is that persistent HPV infection is linked to cancer development. So how are we going to identify patients with persistent HPV infection if we don't test for HPV?
Right.
So it's a very logical argument. So now what should happen is that the third barrier, people will say, what am I going to do with the positive patient? Am I going to refer everybody to an ENT doctor? Am I going to do this? I'm going to cause people to panic and be concerned, right? So the reasonable approach would be that we are testing because we want to identify the patients that have persistent HPV infection. So that means that after one positive, maybe we need to retest in 6 or 12 months. Maybe you want to do it again. Maybe somebody who's more concerned, somebody who has a relative that was that died or had throat cancer, that person could be immediately referred to an oral surgeon or an ENT doctor. And the ENT doctor will put that patient on a follow-up. They can screen them, can see them every year, just like what we do with a lot of other diseases. And then
breast cancer, yeah,
exactly. And then you scope. The ENT doctor can put a scope, and the scope can identify the early lesion, and you remove the early lesion. So now we are putting, first of all, is the patient selection. We're trying to select the patients that require that extensive follow, right? We think that every patient in the dental practice needs a comprehensive exam. It's a no-brainer. You have to look for oral and oropharyngeal, and you have to do that. But on top of that, if the patient is positive for HPV, then that patient needs to be retested. And if the patient is identified as having persistent HPV infection, then we can refer them to an ENT doctor. I think if we do this, we're probably going to find a lot of precursor lesions.
Yeah. So how long does it usually take care of itself or go away if it does? Like if you see it every 6 months, do you retest every 6 months, or is that?
Yeah, so people say under 2 years, usually it resolves, the cases that resolves on its own between 18 and 24 months. So I feel that if you retest in 6 to 12 months, and if you want to add another test, if the patient is negative, add another test in, and just whatever happens to identify the patient with a persistent infection. And I wouldn't be surprised also that patients they can be positive, negative, and then they turn back positive. That is possible too. And it happens in the cervical canal, right?
Yeah. And so maybe also like some of their other risk factors. So if somebody has a lot of different factors, you'd probably refer them sooner than if it was somebody that otherwise doesn't have any.
Right. And also remember, smokers are at higher risk of getting infected with HPV just because of the impact of smoking on the mucosal surfaces, right? So that somebody with a weakened immunity, maybe someone who has gone through chemotherapy, or someone who has acquired immune deficiency, diabetics, there's a whole list of patients that can be identified as people with compromised immune system. And those are the individuals that maybe, need to be looked at more frequently. But none of this would happen without patient and practitioner education.
Right. And so what do you recommend besides screening? How do you recommend? Do you have tools or you use to screen or swabs, or do you have kits or do you lights, or what do you recommend that we can incorporate?
We have a kit, and our website is omnipathology.com. So we have a page for oropharyngeal HPV for patients, and then for dental practitioners and healthcare providers. We have 2 separate pages, and in each one we have information needed to educate. So we have the kit itself is a swab and a tube that has preservative, just like the COVID swab. The COVID swab used to go in the nose. This one, it's in the oropharynx. We have a video, of course, online that shows the actual swabbing of the oropharynx. So we have that, and physicians, any practitioner can reach out to us, and we ship them the kits, and then they swab the patients, fill out the requisition, and send it to us, and then we usually report it within 24 hours.
Okay. And then what could you see physically if you're not doing a swab test? Is there something that you could see physically besides feeling before it gets to be bumps and lumps?
That's interesting. So typically a positive HPV patient will not show anything. They will not have symptoms, and they will not have any signs. There will not be any visible appearance to the HPV infection in the throat. That's something about HPV.
So until it's too late, or until it's really progressed.
And actually, I did some reading on the. There is something unique about tonsils. This is the reason why most of these cancers develop at the tonsils. The tonsils has 2 features. One is that it's a place where you have transitional epithelium, which is epithelium transitioning from one type to another, very similar to the transitional zone in the cervical canal. Other thing that's unique to the tonsils is that the tonsils has invaginations on the surface, which are called the tonsillar crypts. So these invaginations is the surface is dipping inside. This gives access to the HPV virus, which is actually specifically HPV 16. So we look for 14 high-risk HPV types, and HPV, as you know, there's over 100 types of HPV. Our test covers 14 high-risk types, and this is exactly what we look for in the cervical canal. And then what happens is HPV 16 is responsible for about 90 to 95% of HPV-related cancers. So HPV 16 is known to have this affinity to the basal layer. The invaginations in the surface, in the mucosal surface, gives access of the virus to that basal layer, and that basal layer is where this is the dividing layer of the mucosa, and that's where cancer usually starts. So it's something unique about the anatomy of the tonsils that allow it to become hard to harbor HPV virus, HPV infection.
So should I get my tonsils out?
Oh my God, this is okay. So here's I can share with you some studies. There have been studies about lower incidence of oropharyngeal cancer in individuals that had their tonsils removed when they were children.
Wow.
However, recent studies came and they said, well, but we don't really think that this would be a good, effective technique to reduce the incidence of HPV. And I tend to agree with that. However, I can probably predict that the future will show studies where when somebody tests positive for HPV and they show to have a persistent HPV infection, I probably think that removing the tonsils in a patient like this could significantly improve that patient's chances of living cancer-free. Then I think that this would be a much smaller group, and this group will probably benefit significantly from removing their tonsils.
Yeah, I mean, if it's that preventative and if it can prevent cancer, and it doesn't seem like there's a reason that we have to have tonsils, which I would think tonsils would help us fight off cancers myself, but geez.
But you see how this is so logical? Like you intuitively felt, oh, maybe we should remove tonsils. It is actually scientifically sound. As long as we're not gonna go around and remove everybody's tonsils. Right. We're gonna be doing it on a select group of patients. So people telling us, well, we don't know what to do with the positive HPV patients. So, yes, I agree. The data are not there yet, but that could end up becoming a very logical way to do with patients that have persistent HPV infection.
Yeah, it makes total sense. I mean, if we do it because they have, if they get like ear infections a lot or tonsillitis a lot, we remove them. So yeah, definitely to prevent cancers, right?
Yeah.
And so what would prevent people from doing this? Is it super expensive to do a swab test, or is it?
It's an affordable test. It doesn't cost more than what COVID it is. If you compare that to, I think the most recent study is saying that it costs about $140,000 for treatment of oropharyngeal cancer. And that doesn't include lost wages to the patient. That's just like, medical cost is about $140,000 a year. And you add to that the patient's lost income because they're out of work and they're being treated, it becomes a lot more. And the cost of that test being done once or twice a year is extremely insignificant compared to that.
Yeah. Okay. So we can go to your website and look as healthcare professionals and look for that. Yeah, for sure. So I think most of it is getting the word out and educating people, getting some of these simple tests preventative tests to be done.
And promoting this proactive spirit, meaning that when we look at certain diseases that are screened, such as colon cancer, breast cancer, cervical cancer, all of these diseases, when they are screened because there is an existing screening guideline. Because throat cancer doesn't have an established guideline for screening. That does not mean that the medical and dental communities should sit and wait for those guidelines to descend. If something is cost effective, scientifically sound, achieves benefit to the patient, it should by all means be pursued. We're not going to do an MRI that costs thousands of dollars or something like that. This is a swab.
Yeah.
And it's a PCR test. Technology is not expensive. And none of what we're doing is reinventing the wheel. We're really applying the same approach that cervical cancer, which is an HPV squamous cell carcinoma.
Yeah. So educating healthcare professionals, but also people, the public, because they can look for it or ask.
To be proactive, because if we learned anything from the pandemic, is that a lot of people started learning about how do I do this, how do I do that, and for people to go out and get a test that's CVS and local pharmacy, and to be proactive about learning about science and diseases and their health and wellness. It is a wellness approach that is really needed to be encouraged, and we need to really be proactive about it.
Yes, absolutely. And so I see that you said you're an educator as well.
Yes.
Do you do lectures and stuff on this, or where do you speak?
I actually just presented at the California Dental Association. I give a lecture on oropharyngeal HPV. I'm a GI pathologist by training, and I love teaching. So I have given multiple lectures on GI pathology. I love what I call a systematic approach to things. I'd like to, help the pathologists become organized when they look at the slide has so many cells. And when you develop a systematic approach where you're going to be looking for things in order, and you're going to, once you identify a feature, an abnormality, should trigger looking at different things. So it's just basically helping develop this flow chart in your brain that allows you to address every possible diagnosis. And I really enjoy doing this a lot because I think it's a way to be organized. As a scientist, when I did research before pathology, someone taught me, one of my first lessons as a bench scientist is your bench has to be organized, because when your bench is organized, you can be very efficient and you eliminate opportunities of errors, right?
Right.
It's the same thing in your brain. The brain has to be organized so you can just go through things systematically, and you allow yourself to address every possible outcome. And the other thing that I like to teach about is biases. I am really into the biases and its impact on decision making. So I did some reading on this, and I came across a book called Thinking Fast and Slow. And it opened up a lot of things in my mind about pathology and the decisions we make in the pathology, and in general in the medical community. Decisions are being made, and how you try to eliminate biases. If you identify the bias, you have a higher chance not to fall into it.
So it's called Thinking Fast
and Slow.
And so, like, not judging a book by its cover, or you don't know what's somebody's
right.
got. Yeah.
There's a lot of in medicine in general. There is a lot of opinions. You can have a consensus conference where a group of pathologists are looking at one difficult case, right? This is a perfect opportunity for a wrong decision to be made, because sometimes you have something called groupthink. A dominant voice, maybe the most experienced pathologist, would have a thought that could dominate the conversation, and a good idea by a junior pathologist may never be spoken of because the person may be intimidated, right? Dissenting opinion, right? So what needs to happen in an environment like this is that the leader of this consensus conference needs to basically be aware of this groupthink trap and allow every opinion to be heard. And the way to do it is that before the conference, we know which cases we're going to look at. The cases get distributed on the participants of that conference, and every person writes his or her own opinion about the given case anonymously. And they're given to the leader of this conference, so that when they review the cases, they make sure that every opinion has been addressed. That allows the group to come up with a better idea, not the most dominant or most senior or most experienced opinion. It needs to be, because experts can make mistakes.
Yeah, and you want a lot of different eyes on there, not just, yeah.
And the worst thing could happen is that a good idea would never be mentioned because someone is intimidated by the environment.
Yeah, like a senior doctor, a pathologist. I mean, I've been in those situations where people just really look up to this one person, and
right.
So nobody would ever question that person, but maybe sometimes you need to, if there's
is one of the biases, but there's a lot of other biases. There's something called hindsight bias, and there's a lot of availability heuristics and things like that I feel my pathology community needs to be educated about. And I gave a few lectures on biases and decision making, and I think it resulted in a lot of amazing conversations that we all come out of learning more and helping our way of practicing pathology.
Yeah Very important. And so, not to be biased, but is there a certain prevalence in age, like age or sex, that we should be looking for?
Yes, that's a great question. So, number one, there was a point where It was an older age, like about in their 60s. We're seeing more of throat cancer, and then there was a recent trend where it increased in the population of 40s. But in general, most cases of HPV related cancer, throat cancer, 82% in men, 18% in women. So there is a more men predominance in that. They keep moving the age range, but at one point there was exclusively older patients in their 60 to 69, and now I think we're seeing more and more in patients in their 40s.
Okay. Yeah, it's like 60s. I would think like drinking and smoking, smoking was a big thing a while ago. And maybe now because younger people are vaping, which is just as bad, right?
Yes. And of course, we in 1980, about 20% of throat cancer cases, only 20% were HPV related, and the majority were because of smoking. And now gradually HPV related cancer have increased, and now it's about 70%.
Wow. Yeah, you wouldn't think that would happen. You think it would be decreasing over time and education. And
right. And this is also a good conversation, because there are things that could be like practicing safe sex could also result in decreasing this, because it's all maybe helping our patients realizing that there are ways to practice safe sex that could result in reducing the risk.
Yeah, and being able to have that conversation with them, and educating them on on the importance. Yeah.
And it falls along the line of the patient. Oral health is a gateway to overall health.
Yes.
I'm a GI pathologist, so I've always wondered, why isn't oral pathology part of the GI pathology training? It's not.
I know. And I first got into hygiene school, that's the first part, or digestion, or actually nutrition. I was surprised. Nutrition, we had a lot of nutrition. It all starts right here.
Yes, exactly.
Your GI tract starts right here, right?
Absolutely.
But medical doctors start like where? Right here.
Yeah, it should also the neck. Yeah, maybe in the neck. But I feel that oral pathology, if I had to redo my training, I would definitely spend time doing a lot more oral pathology.
Yeah.
If I knew that I was going to get into oral HPV testing.
Yeah. Well, thank you so much for being a guest today. You got so much to share. And do you have a lab back there, like a science lab?
Yeah. And I'm here at Omni Pathology. The rest of this is my office, but the rest of it, there's like a huge lab with PCR instruments and pathology equipment and things like that. So we have a full lab here in Pasadena.
Do you do tours or let people come in and
I would love to do that. And actually, one of my dreams is to coordinate for students, because a student can come in and take a tour of the lab. They get inspired about doing, science, but when they see the art, they may feel that there is a bridge between art and science. Yeah. We want the young generation to realize that there isn't anything that can stop a scientist from being an artist, or stop an artist from being interested in science. Yeah.
And it kind of goes together, like music, art, science.
Yeah.
It's kind of all.
Yeah.
And so, it'd be fun if I'm ever in Pasadena to come in and take a look. And
yeah, please. And I want to thank you for your interest in our topics. And I think that as more in your domain, especially those who are out speaking in podcasts and things like that, this will give us a way to communicate this really great cause about trying to fight throat cancer, HPV-related throat cancer.
Yes, and I do talk about infectious diseases when I do infection control courses to dental professionals. So I'll throw this in there just as a side note and get the word out.
Fantastic.
For sure.
And if you're ever looking for any resources or anything like that, please feel free to contact me. I'll be there. And so it's omnipathologylab.com. Yeah, omnipathology.com.
Okay, and I'll put that in the show notes and then on our website as well.
Excellent.
Too. That was easy for people to find it.
Fantastic.
Yes.
Great. Okay, great. Thank you so much for your time and for having me as a guest on your podcast.
Thank you. Yeah, and I'd like to follow up. Hopefully I'll see you out there speaking somewhere, and keep in touch.
I will.
Sure. Okay. Thank you. Okay. Bye.